Good afternoon. Today we're going to talk about the changing new healthcare codes for clinic visits. This is a very important topic. As of January of 2021, the way that all the codes are built is going to be completely different, so we need to understand this. Normally, I'm kind of cautious about any new change in healthcare because, let's be honest, all of our experience in healthcare has been somewhat negative. But this time I am actually optimistic because I believe those codes are going to be much better than previously. First of all, they are going to be simpler. An example of this is elimination of some codes like 99211, which were not used anyway. The way that they are going to be analyzed or built is going to be much more practical and much more in sync with how we physicians practice nowadays. And they are going to be better reimbursed. In some cases, up to 35% work RVUs for some of the codes that are currently built or currently used. And so this is all good news, but we have to understand how to put these codes into use and how to build the correct way for them. In a nutshell, the visit code is going to depend from now on only two things: medical decision making and time documentation. I'm going to show you in the next slide a comparison between the current system that we used for billing and coding and between the new proposed system as it will be implemented as of January of next year. So what section of the note counts? And I put counts in quotation marks because you have to remember these changes are not changes in the way that necessarily you document for maintenance of care or for communication with other providers or even for medical legal purposes. You are simply going to pay attention to some things more than others when it comes to billing and coding. So for example, in the current system, the history of present illness, as you can see here, kind of 1 to 3 elements are needed for level 3 and 4 or more elements are needed for level 4 or 5 billing, whether it be new or return patient. But the new system, it's not going to be applicable at all. Past medical, social, family history just needed to be present in the current system for billing and coding. However, for the new system, that's not going to be kind of taken into consideration. Review of system, same thing. And exam, same thing. Meaning that whereas in the current system, there are several things that have to be taken into consideration when billing or coding for a visit, this current system implemented as of next year is only going to care about the medical decision making, which you have in the assessment and plan section of the chart. Again, you should document, of course, physical exam if you do it. You should also document anything in history of present illness that you note or take note of. Those things don't necessarily change because the current system of billing doesn't take them into account, but they are just not going to be important for the billing aspect of things. Now, how do we analyze the medical decision making and how do we determine the medical decision making in assessment and plan to make a decision as to the level of the visit? We're going to see that on the next slide. So the summary of changes is going to be that brain work is going to be rewarded because the emphasis is really on the medical decision making, the thought process behind any treatment you give, any surgery you plan, any intervention you want to do. Time spent is rewarded, and that's a relief for a lot of us who have sometimes to spend more time with some patients who need more care, who need questions to be answered, and so on and so forth, especially that the new changes are going to take into account whatever time you spend, including even the time that you spend in documentation. And the third thing is that everyday clinic issues are acknowledged, as you will see in the next slide, where we're going to break down those changes in medical decision making. Some changes or some factors like social background, the interaction with insurance companies or with medications that were rejected and so forth. You spend a lot of time in things like this, and in the previous system they weren't acknowledged or they didn't factor into the billing. Now they will be. So let's go ahead and see how that is going to count. Okay, so when it comes to medical decision making, this is the most important slide, and this is the most important table that you need to know and understand to determine the level of the visit. It basically depends on three things: the problem, analysis of the problem, and the risk. So two of the three determinants are needed to determine the level of the visit, and they are obviously the higher determinants, meaning if you have two elements in level 4, the problem meets the requirements for level 4 billing, and the risk meets the requirements for level 4 billing, but analysis you only have level 3, still the note as a whole counts as a level 4 billing. Same thing for any of the other levels. So basically you have to have 2 out of those 3 things at a certain higher level to meet the requirements for that level. All right, so let's go over what is problem, or how do we assess the problems and how do we take them into consideration. For a level 3 billing, you need to have either one uncomplicated acute problem, one stable chronic problem, or 2 or more minor injuries or problem. Now, I put it in that particular sequence because if you notice, there is something for the urgent care physician or the surgeon, and there are things that are more used in family practice or internal medicine or primary care type of situation. And you'll see that pattern repeated in all the levels. But this is level 3. How about level 4? Well, level 4 is if it's one acute systemic kind of presentation or complicated issue. For example, if somebody had the flu, then in that case, that has systemic symptoms, obviously, and in that case, that would count as a level 4. Or COVID-19 infection. Well, it has a lot of complications. There's a lot of things going on, so that basically qualifies for a level 4 visit. If it's one new diagnosis or one chronic diagnosis but complicated, as diabetes, for instance, 2 or more stable conditions, any of those would qualify as a level 4 problem. Now, level 5 is one acute life-threatening situation, one chronic but with severe flare-ups. So for example, if it was diabetes, it would not be just uncontrolled diabetes, it would be very high blood sugar levels, 500, that qualify the person to visit an emergency room or something of the sort. One chronic problem with medication side effect. Again, if the example is about diabetes, if you started the person on the previous visit on a medication for diabetes, this time they are presenting with a severe side effect from that medication, and you have to address that, that would qualify as a level 5 problem. The second row here is analysis, and analysis means that you either review or order, or that you have some form of a discussion or interpretation of a test result. Let's break it down. For a level 3 billing, you need one of 2 things in analysis. Either review and order 2 items, or have an independent historian. Either one of those 2 qualifies as a level 3. I will talk more about this in the next slide and break it down further, because I think this is probably the most complex part of the entire table. Level 4, you have to have one of three. Review and order 3 items, interpretation of test, and discussion. We'll also see what that means on the next slide. Level 5 analysis means 2 of 3. So it's the same items as in level 4, but instead of 1 out of 3, you need 2 out of 3. Either review and order 3 items, interpretation of test, or discussion. You need 2 out of those. And finally, when it comes to the medical decision making third item, which is risk, you can qualify it as either low risk for level 3, moderate risk, and those are simply examples of what qualifies as a moderate risk: minor elective surgery with risk factors, or major elective surgery without risk factor. When you are discussing, as the surgeon, you are discussing this upcoming surgery with the patient, you just decide whether it is a minor elective with risk factors or major elective without risk factors. That qualifies you as a level 4 risk. Medication management is level 4, and social restrictions. Remember, we talked about how social issues affect the evaluation of the level of the visit. Now here it is. Social restriction means that you order a medication, it's too expensive, the insurance does not cover it or covers it partially, so you have to switch to another medication. That discussion, when it is noted in your assessment and plan section, that qualifies as a level 4. Now level 5 risk means, which is high risk, means either a major elective surgery with risk factors or major emergency surgery. That is meaning a discussion that you are having either about an emergency surgery or an elective surgery with a risk factor, but it has to be major. Decision about hospitalization or decision about DNR or de-escalation of care. Let's say a person is, you're dealing with end-of-life issues. You need to discuss with the family and with the person, the patient, about DNR decisions. How are you going to go about the end-of-life issues, hospice, home hospice, and all these are qualify as a high risk that goes under level 5. And medication management, if there are side effects or requiring a specific intensive monitoring of the treatment or expected toxicity of the medication, that would be a high risk. So like for example, giving Coumadin and explanation of what can happen with the medication, what to expect with the medication, or administration of insulin, especially in somebody who's naive to insulin, hasn't taken it before, that would qualify as a high risk. All right, let's dig deeper into that analysis section, which we said is the one that requires kind of the most work to understanding exactly what that means. So basically, there is something called that they refer to as category 1, which is review and order. You will see that in each one of the 3 levels, level 3, level 4, level 5, you will see something about review and order. What do they mean by this? If you are reviewing a test, okay, so a test result, for example, lab test result, that counts as 1. Now, the good thing is every unique test counts as 1. So if you ordered a lab and ultrasound for a patient, and the patient is coming back for discussion, you reviewed the labs, that's 1. You reviewed the CT report, that's 2. So you got 2 points from that, right? If you reviewed, for example, notes from different sources, each one of those sources counts as 1. So for example, you're a specialist seeing patient for cancer, malignancy, all right? You reviewed notes from the referring physician, that's 1. You reviewed notes from hospitalization the patient had, that's 2. If you reviewed notes from a third specialist, That's 3. So that's good, because as you know, in real life and in practice, you get a lot of scenarios where, as a specialist, you have to review multiple documents, or 50, 60, sometimes pages of document. Now all that counts, and it counts here in medical decision making, but it also counts in time documentation, as we shall see in the next video that I will make. Now, you will also notice in the guidelines something that says independent historian. What does independent historian mean? It means that if you have a patient coming with somebody who, for whatever reason, needs to explain the situation to you, so the patient himself is incapacitated or incapable in some sort of sharing the details of their situation at home, and that person, caregiver, is talking to you. So whether it is because it's the parent of a child who has to explain the situation to you, or the daughter or son of an elderly patient who is just unable, because of dementia or because of cognitive issues, to express what's happening, that is counted as independent historian. And I put historian in quotation marks because they refer to it as historian, even though, like, technically you are the historian, they are the informant. But anyway, it's semantics, so I'll just leave it as it is, as historian. Review of results. Each type of results counts as 1, as we saw, and all of these things add up. So if you reviewed labs, from a unique source, meaning you reviewed the labs that the patient had bringing with them, you reviewed ultrasound that the patient did, you reviewed notes from referring physician, and you reviewed notes from hospitalization, that's 4. So you already met by that the requirements for that review section. Now that's a review, but ordering tests works the same way. So if you order labs, that counts as 1. If you order an ultrasound, that counts as 2. So you can easily see how that, in any kind of a little bit complex visit, you can order, or you can get more than 5 or 6 points and fulfill that review and order category, which is referred to as category 1, very easily. All right. Now, obviously, just be careful that ordering specific tests doesn't count. You don't count each specific test as 1. So, for example, if you're ordering a test, CBC, and then ordering CMP, that's not 2. All the labs that you order, even if it's 20 labs, all the labs you order, that's ordering labs. That's 1, right? But if you order a specific different kind of test, so a CT scan, a radiology test, that counts at 2. Same thing if you're ordering an ultrasound and a CT and an MRI, not that you would get to do that clinically in an encounter, but I'm just saying if you order all 3, that counts as 1, because that's a kind of test that you are ordering. So that counts as 1. I hope this is clear. Now, the other thing that you will see also in the guidelines that needs some explanation is independent interpretation of results. What does that mean? That means if, for example, you're a surgeon, you're looking at a CT scan that was done on the patient. You're looking at it yourself. You're not looking at just the report. You're viewing the images because you want to see where you're going to go for surgery or some details that might not have been on the report. That by itself is called independent interpretation of results, and you have to make note of it in the chart in the assessment and plan section, and that qualifies by itself as a category. The third item is discussion. Now, discussion of the patient's case with other physicians or other professionals, meaning that, let's say after the visit, you are a specialist and the primary care doctor has referred this patient to you, and you notice something that needs a further discussion. You need to discuss the case with that primary care physician. So you call the primary care physician and you draw her attention to the issues that are present and how are you going to coordinate care from now going forwards. That counts as category 3. It doesn't matter per se who you're talking to, as long as it is a physician or a professional involved in the care of that patient. All right, I hope this is clear. So summary is, as of January 2021, visit codes will depend exclusively on medical decision-making and time documentation. The changes will simplify assessment of medical work done, will be practical for physicians, and will improve reimbursement. Medical decision-making evaluation depends on the number and complexity of problems addressed, on the analysis of data, and on the level of risk. Now, I have to say a few things before we finish. Number one is I didn't mention at all 99212 or 99202 because practically speaking, I don't see many people doing it. Obviously, the level 1 was completely eliminated. Level 2 still exists, but I didn't incorporate it just so that we don't confuse issues. We focus on the important stuff. The second thing I want to say is this is not the end. There is another video that I'm going to make about time documentation and its importance and how to capture that time documentation in your note. And then I'm going to make some videos about some cases so that we can understand how this applies in real life. And I'll try to make the cases applicable to either surgical practices or internal medicine practices or even urgent care. So, until then, please let me know if you have any questions about this. Email me or put a comment in the comment section on the YouTube video, and I hope all goes well with you, and thank you for your attention.